Part 2 of this section on the pancreas will be presented by Dr. John Dewitt, who is a friend and professor of medicine, director of endoscopic ultrasound at the Indiana University Health Medical Center. He will be sharing his insights about mucinous cystic neoplasm management, surveillance, ablation, or surgery. And here's Dr. DeWitt's video.
Hello, my name is Dr. John Dewitt, and I am professor of medicine and the director of endoscopic ultrasound at Indiana University Health Medical Center in Indianapolis, Indiana. And I would like to welcome you to this talk entitled Mucinous Cystic Neoplasm Management, Surveillance, Ablation, or Surgery. These are my disclosures, none of which are relevant to this talk today. Objectives for this talk are first to describe the types of pancreatic cysts that we may see, second to describe the indications and complications that may occur for surgery of pancreatic cysts, and finally to describe the novel technique of EUS-guided pancreatic cyst chemoablation. I will first review the indications for and contraindications of the procedure, second to review the technique, third potential adverse events that have been described, and finally future directions. Pancreatic cysts may be classified in several different ways, including the type of epithelium, if present, that lines the cyst, and any malignant potential that the cyst may have. A pseudocyst is a cyst which complicates acute or chronic pancreatitis and therefore has no malignant potential since there is no epithelial lining. The most common pancreatic cystic neoplasms that we see are mucinous tumors, such as the mucinous cystic neoplasm and intraductal papillary mucinous neoplasm, and these by definition are premalignant. Serous cysts are lined by cuboidal epithelium and have nearly no malignant potential. Only a few cases of malignant serous cysts have been reported. Squamous epithelium lines the lymphoepithelial cyst, which has no malignant potential. Acinar cell cysts can be malignant, and there can be rare malignant tumors that degenerate and form cysts. Of these, neuroendocrine tumors and solid pseudopapillary tumors are premalignant, whereas the others are either malignant or have no malignant potential. It is important to recognize that the progression of malignant degeneration in mucinous cysts progresses along a well-described pathway of a normal duct to an adenoma or low-grade dysplasia, borderline atypia, carcinoma in situ, and invasive cancer. There are genetic mutations that describe this, but this progression is beyond the scope of this talk. Microscopically and macroscopically, the description for microscopic changes are pancreatic intraepithelial neoplasia, which can occur both in the main pancreatic duct or its branches. The mucinous cystic neoplasm is a macroscopic description primarily of tumors present in the body and tail of the pancreas, primarily in women. IPMNs can involve the main duct or its branches, are primarily located in the head or body of the pancreas. It's important to note that 5-year survival following resection of malignant cysts is much better than that for the standard pancreatic ductal adenocarcinoma. The 5-year survival for resected adenocarcinoma without cystic degeneration is about 20 to 25%, where it is perhaps twice that for malignant cysts. Over the last 10 years, there have been multiple guidelines published by various professional groups for management of pancreatic cysts. The most commonly ones used are the American College of Gastroenterology, which was published in 2018, the Sendai and revised Fukuoka guidelines, which were published in 2012 and 2017, the AGA guidelines published in 2015, and the radiology guidelines published in 2017. The ACG guidelines are focused on patients who do not have a strong family history of pancreatic cystic tumors or cysts, or have a genetic mutation that may predispose them to pancreatic cancer. So in other words, these are for average risk patients regardless of symptoms. The patients that are managed with the IAP or revised Fukuoka guidelines are only for mucinous cysts and not the other cysts. The AGA guidelines published in 2015 are for asymptomatic cysts, and the ACR guidelines published in 2017 are only for incidentally identified cysts on imaging. Most of the guidelines agree on what constitutes a patient with high-risk cyst, and these would include patients who have jaundice, pancreatitis, elevated CA19-9, or, in the case of the ACG guidelines, new or worsening diabetes. There is generally fairly good agreement among the four guidelines on what constitutes a high-risk cyst by imaging or cytology. These features include a cyst measuring at least 3 centimeters in size, dilation of the pancreatic duct to at least 5 millimeters, a mural nodule, which generally is described as enhancing on imaging, focal dilation of the pancreatic duct or a stricture which may indicate a tumor present. Some guidelines recommend increased surveillance for a patient who has an enlarging cyst measuring at least 3 to 5 millimeters over a 1 to 2 year period of time. And if cytology demonstrates any high-grade dysplasia or cancer, this would be considered a high risk. Patients who have any of these features should be considered for referral to a multidisciplinary evaluation or a surgeon for consideration of resection. Now that we've defined which patients should be considered for pancreatic resection, it's important to note that this surgery should be done in high-volume centers. This slide illustrates 5 studies over about a 20-year period of time in different countries or locations using different databases involving about 20,000 patients. These studies define high-volume surgery as generally between 15 and 25 operations per year, although this number varies. And the studies consistently show that volume is an independent predictor of mortality, or the risk of death is higher in lower volume centers. Furthermore, the risk of short-term survival may be lower in lower volume centers. Although it is clear that pancreatic surgery should be performed at high volume centers, even high volume centers experience significant morbidity and rare mortality from this operation. This slide illustrates 7 studies published over about a 10-year period of time involving about 1,000 patients. And consistently, morbidity from pancreatic surgery is between 20 and 30%, with mortality between 2 and 4%, and length of stay following surgery, predominantly a Whipple operation, is between 1 and 2 weeks. Now, this talk is supposed to focus on mucinous cystic neoplasms, which are tumors that involve primarily the body and tail of the pancreas in middle-aged women. And this slide illustrates some of the earliest experience with laparoscopic distal pancreatectomy, which is generally the procedure of choice now for this tumor when it is required. These 5 studies involving between 9 and 22 patients showed that the length of stay is between 4 and 6 days. OR time is about 4 or 5 hours, but major complications still occur in about 20 to 25% of patients, primarily including fistula formation, and even conversion rates are between 10 and 25%. Mortality is extremely rare with this surgery currently, but in these series, some patients, in fact, did die from the operation. So the question remains, is laparoscopic distal pancreatectomy a preferred operation to open distal pancreatectomy for patients such as those with mucinous cystic neoplasms? This meta-analysis and systematic review was published in 2012 involving 18 studies and 1,814 patients. About half of the operations were open and half were laparoscopic. And what can be seen is that laparoscopic distal pancreatectomy compared to open operations has less blood loss, has a shorter length of stay by 4 days, has 10% fewer complications, and less surgical site infections. However, there's no difference in OR time, the rates of margin positive for cancer operations, fistula, or mortality. So it is clear that surgery for the pancreas should be done at high volume centers, and whether the operation is a Whipple procedure or a laparoscopic distal pancreatectomy, any operation on the pancreas is associated with potential mortality and morbidity between 20 and 30%, including complications such as gastroparesis, infection, or fistula. So then why offer patients the option for EUS-guided pancreatic cyst ablation? Well, it may lower cancer risk if the cyst may be treated. It may lower costs over time. There may be a psychological benefit to the patient to have a procedure rather than surveillance. It may potentially avoid more invasive procedures such as surgery. And though yet unproven, it may help with outcomes and survival. As with any invasive procedure, there are potential complications with cyst ablation. They include normal complications such as infection, pain, pancreatitis. Any ablative procedure does carry the risk for incomplete ablation or buried cancer. Since more procedures are required in the first several months of the procedure, the cost may be higher up front, and it is possible that there's no change in either the risk of cancer or life expectancy or outcomes. The basic technique of EUS-guided fine needle injection or cyst ablation involves passage of a linear echo endoscope into the stomach or small intestine and first aspirating the pancreatic cyst. Once it is nearly collapsed with the needle still visible, then alternating saline or alcohol is lavaged over a 3 to 5 minute period of time. After this is performed generally between 6 and 8 times over that few minute period of time, then chemotherapy is injected into the cyst and then left in place. Another way of illustrating the theory behind EUS-guided fine needle injection or cyst ablation is that if you have a cyst which is lined by epithelium from which any cancer may develop, if you take a linear echo endoscope and lavage alcohol or saline and then follow that with chemotherapy, that cyst will then shrink in size due to the fact that there's less viable epithelium that lines that cyst. Cyst ablation may be performed 1 or more times following that, and by follow-up imaging, the cyst hopefully resolves because there is less epithelium or no epithelium present, and imaging demonstrates cyst resolution. Cyst resolution in most studies is defined as less than 5% of the original volume of the cyst by imaging. The device that we use for EUS-guided pancreatic cyst ablation is a through-the-scope balloon inflation device, which we place a 30 cc syringe over top, tape it down, and have an attachment on the front of it, which we then place onto the 19 or 22 gauge needle. As can be expected, this procedure requires 2 physicians, one to perform the EUS procedure and the other to perform the chemotherapy injection. This video illustrates the procedure of EUS-guided chemoablation. This is a patient who had a 2.5 centimeter cyst in the head of the pancreas and refused consideration for surgery. Initially, the EUS-guided puncture is performed. The cyst is then aspirated completely. And then after aspiration, either saline or ethanol is used to lavage the cyst. And the theory behind this is that it will stir up or agitate the cells that line the cyst prior to chemotherapy injection. After this is performed for 5 minutes, then the chemotherapy is injected using the device that you saw on the previous slide. And this chemotherapy is injected to a volume equal to that which is initially aspirated. The goal would be to replace enough to maintain the original volume or size of the cyst as it was measured prior to treatment. This was a 2.5 centimeter cyst, and as you can see, after chemotherapy injection, the cyst now measures 2.6 centimeters in size, which is sufficient, and the procedure would then be completed. If EUS-guided pancreatic cyst ablation is going to be considered, it is important to know which cysts may be considered for treatment. Early in our experience, and that from other investigators, it is clear that the cysts with the greatest likelihood of successful treatment are those that are benign, 2 to 5 centimeters in size, and having 5 or fewer septations. Cysts that have more septations are harder to treat because it is possible that the chemotherapy or lavage agent may not reach all locules present within the cysts. Also, cysts that are branched duct intraductal papillary mucinous neoplasms may be very tortuous or have a very thin diameter, which may make treatment more difficult or risky. Absolute contraindications include pregnancy, inability to tolerate sedation, malignant cytology, benign cysts with no malignant potential, and a limited life expectancy. Relative contraindications to treatment would include those with a dilated pancreatic duct, epithelial nodules, duct strictures, more than 6 septations, uncorrectable coagulopathy, or high-grade dysplasia. The next 3 slides illustrate the literature on pancreatic cyst ablation between the years 2005 and 2017. These studies enrolled generally between 20 and 90 patients. The largest study was published in 2017, enrolling 164 patients. The initial lavage agent used was ethanol, but this was changed to ethanol and paclitaxel by the Koreans once it was realized that ablation rates may be higher with this. Most cysts are between 2 and 3 centimeters in size. Mucinous tumors are generally the preferred tumor treated. However, some studies do enroll serous cysts. It's important to note that there are some indeterminate cysts that are treated because it is unclear sometimes from cytology, imaging, and genetics if the cyst is mucinous or not. Complete resolution by follow-up imaging after ethanol ablation is about 1/3, with partial resolution in about 10 to 20%, and no response is seen in about 2/3. When paclitaxel is added to the injectate, resolution rates double to between 50 and 60%. In the largest study involving 164 patients, treatment with ethanol and paclitaxel resulted in treatment resolution in 72%, with partial resolution in 20%. This slide illustrates the complications that have been reported with EUS-guided cyst ablation. The most common side effect that is concerning is pancreatitis, which develops between 2 and 10% of the time. Abdominal pain occurs between 10 and 20% of the patients. There are rare complications such as bleeding, fever, peritonitis or ileus, venous thrombosis, and pancreatic duct stricture formation have also been reported with this technique. It is important to consider these adverse events with pancreatic cyst ablation in context between other endoscopic procedures and pancreatic surgery. As already illustrated, EUS-guided chemoablation with alcohol results in severe adverse events between 3 and 10% of the time. This compares to less than 1% and 0.2% for EUS-FNA. Complications are higher for EMR and ESD and ERCP. Now, compared to pancreatic surgery, which has a severe adverse event rate between 20 and 40% and a mortality rate between 1 and 5%, the potential adverse events with EUS-guided chemoablation are much smaller. As I'll illustrate in subsequent slides, if an alcohol-free lavage chemoablation technique is performed, adverse events are less than 1%. Mortality has not been reported to date with EUS-guided cyst ablation. Another way to look at the potential role of EUS-guided cyst ablation compared to surgery is to look at costs. As already illustrated, if you perform a Whipple, mortality rates are between 1 and 5%, with serious adverse events between 20 and 40%. And this operation in 2016 US dollars is about $150,000 for the operation and hospital stay. If you compare that to EUS-guided cyst ablation, there's been no reported mortality. Serious adverse events are between 3 and 10% when alcohol is used, and less than 1% when an alcohol-free regimen is used. However, costs in 2016 dollars are around $5,000 for the procedure. This slide illustrates the EUS pictures of a 3 centimeter mucinous cyst in the head of the pancreas that was treated in October 2014 with 4 lavages of alcohol, followed by injection of 4 cc's of dilute paclitaxel, which was left in place. This is a picture of the cyst. and then the needle in the cyst. After lavage is performed and chemotherapy is injected, a typical picture of the cyst is with potentially some air present and the chemotherapy left in place. The baseline CT scans in this patient showed a 3 centimeter cyst in the head of the pancreas. 2 months after chemoablation, the cyst had shrunk in size from 3 by 2 centimeters to 10 by 7 millimeters. And 7 months following ablation, the cyst was now undetectable, measuring only 2 millimeters by 2 millimeters on CT scan. This would be defined as a complete ablation, since less than 5% of the original volume was present on follow-up imaging. A very important study was published several years ago by Dr. Matt Moyer from Penn State University, and this study looked at the feasibility and safety of an alcohol-free regimen to perform pancreatic cyst ablation. The reason this was considered an important question was that most of the adverse events, such as abdominal pain and pancreatitis with this treatment, were considered to be due to the alcohol that was required, at least until that point with treatment. And this study took 46 patients, and after excluding 7, randomized 39 to undergo either saline lavage with chemotherapy injection with paclitaxel and gemcitabine, or ethanol lavage followed by infusion of paclitaxel and gemcitabine. 21 patients were randomized to saline and 18 to ethanol. And what this study found was that if you use an alcohol-free regimen, about 2/3 have complete resolution, but with absolutely no adverse events. Whereas if you use alcohol, resolution rates are pretty much the same. However, 6% had serious adverse events and 22% had minor adverse events. So the authors concluded that the use of an alcohol-free regimen did not sacrifice resolution rates, but did avoid the potential for any adverse events. Based on the excellent results from the CHARM-1 protocol, the CHARM-2 protocol has been approved and is funded by the NIH in an R01 grant to Dr. Moyer. And this study attempts to basically replicate in a multi-center fashion the protocol from CHARM-1. This study is still accruing patients, and results should be reported in a couple of years. In conclusion, there are clear guidelines for patients who need surgery for pancreatic cysts, and when recommended, centers that perform at least 20 to 25 operations a year should be utilized. For cysts that measure between 2 and 5 centimeters in size and have fewer than 6 septations, there's an opportunity with EUS-guided fine needle injection to intervene or treat these as opposed to either surveillance or considering surgery in these patients. It's clear from recent studies that ethanol is not required for a lavage agent, and chemotherapy alone with gemcitabine and paclitaxel may be considered. Ablation rates with this regimen is between 60 and 70%, with severe adverse events less than 1%. There are some unanswered questions with this technique, such as can other types of cysts be treated besides those generally performed in clinical trials? Are branched duct intraductal papillary mucinous neoplasm safe to treat? Is long-term resolution durable? We do have data up to 5 years suggesting that cyst recurrence after complete ablation is less than 5%. And ideally, a randomized clinical trial between surgery and endoscopic cyst ablation should be performed to see where each technique might have a role in terms of costs, adverse events, and long-term follow-up. Thank you.